Welcome to the Pain Science Education Podcast, where we discuss ways to treat and reverse persistent pain. I'm your host, Dr. Joe Tatta, a licensed physical therapist and founder of the Integrative Pain Science Institute, where we train practitioners on whole person pain care. This podcast also serves as a public health campaign to support those living with chronic pain. This podcast is for informational purposes only and is not intended to be a substitute for professional medical advice. Hi there, and welcome to this week's episode of the podcast. Today, I'm speaking with Dr. Sarah Case Morris, who is an assistant professor at the University of Michigan, Flint, to explore how mental health and pain science are being woven into the Doctor of Physical Therapy curriculum. Dr. Case Morris shares her journey from being a teaching assistant to shaping the next generation of physical therapists, and we dive into her research on how early career physical therapists, those who are trained in a biopsychosocial model, approach pain differently than those rooted in a more traditional biomedical lens. We also talk about the real-world challenges of implementing clinical practice guidelines, especially when it comes to screening for psychosocial risk factors related to pain and or mental health. Sarah gives us a behind-the-scenes look at how she's integrating pain science and mental health into her teaching, right as CAPTE requirements are evolving to include mental, psychological, and emotional dimensions of health. This is an important conversation about physical therapist practice and how we can help address pain and mental health, both in individuals and the communities that we serve. Okay, without further ado, let's begin and let's meet Dr. Sarah Case Morris. Hi there, Sarah. Thank you for joining me this week on the podcast.
Hi, Joe. Thanks for having me. It's great to be here.
I'm excited to talk to you about mental health. We're going to go into that in the podcast in depth and discuss some of the great things you're doing in the DPT program, obviously at University of Michigan at Flint, and working with students. And a lot of that's going to overlap with some things you're working on in pain management and health and wellness promotion. All these things have overlaps, right?
Exactly.
But first, and I really wanted to have you on because we need more of this, obviously, in physical therapy, where we're taking these three important topics of mental health, health and wellness promotion, and pain management, and obviously insert them into the curriculum so that our new physical therapist or future physical therapist has some kind of, impact on individuals and populations with these challenges. But tell me how you kind of came into this work as an assistant professor.
Yeah, so it's been a little bit of a journey. I started out as a teaching assistant at my alma mater, and I've been in some type of physical therapy education for about 25 years. Mostly practicing in outpatient orthopedics, musculoskeletal care. And early on, I really noticed that a lot of my patients with chronic back pain, chronic knee pain, really didn't respond to the types of treatments that I was doing. So I knew there was something else that I was missing. So really, I started my own journey of just looking into, at that time, we're talking early 2000s, pain science. And it was just starting to kind of take hold. And that really led me to wanting to research more. So I went back to school for my DSC, which is a clinical and research doctorate, and was able to look into an area that was interesting to me, which is the practitioner's attitudes and beliefs around the treatment of pain, but really the perspective of, is it more biomedical or biopsychosocial? And that really led me to look at entry-level education as an area that could be very impactful if the stage is set early on to be open to those ideas.
Yeah. And
Yeah.
what do we have a good idea now of what, I guess, what did your research look at early career physical therapists or physical therapists with a certain amount of years of experience?
Yeah, our first study I did was early career students, actually, because they're a captive audience, and then early career graduates. And then more recently, we did a national study looking at physical therapists across the spectrum. So typically, it's a mixed, finding of some have more biopsychosocial attitudes and beliefs, some do not. And it really comes back to training and that education and whether they've done certifications or specialty board certifications, things like that.
Right. So for example, I guess what you're saying is maybe some of the newer physical therapists who are coming out of school who are more exposed to a biopsychosocial model across the lifespan have some more useful beliefs around pain and the
Hmm.
mental health aspects. But if you've been practicing for a while and you haven't taken courses or you haven't continued that lifelong learning, that it may kind of like slip off there a little bit.
Yeah, that is exactly what we found in the more recent study. So if they had less than 10 years of experience, for example, they tended to have more biopsychosocial oriented
Mm,
approaches.
mm. Interesting. There's almost like this divide that we see now, almost like, if you have less than 10 years of experience, you're maybe more biopsychosocial. And if you have more than 10 or 15 years, obviously, if you haven't kept your learning up, that it's more of a biomedical model where you're approaching people.
Right, right. Yeah, so that's really been my interest from the start. And then I started to branch into more of a implementation science where we looked at are people following the clinical practice guidelines, specifically around low back pain.
Yeah.
And one of the major features that was missing was screening for psychosocial risk factors
Mm.
for further pain and disability. And that was pretty much non-existent, what we found. So,
Yeah. And we
yeah.
know that the clinical practice guidelines are not followed so well by um, licensed or experienced therapists.
Right,
Yeah.
right.
And I think, there's been a lot of talk about it. I do think a lot of that still has to do with the system that we function in as clinicians,
Hmm.
that there are challenges to implementing some of that. But obviously, with all challenges, there are ways to work around them. But
Right.
it sounds like some of your research really said that people just aren't screening for those factors at all.
Yeah, so that was the early part of our knowledge translation study looking at the utilization. So we had done chart audits on 9 clinics and found very little screening happening
The good
within.
old chart audit, right?
I know.
Yeah,
Yeah, for sure. So we're in the process of this grant funded through the Academy of Orthopedic Physical Therapy through the APTA. It's a 2-year knowledge translation study. So we're kind of towards the tail end of that, trying to work on those organizational challenges,
yeah.
structural challenges, clinician education, and even, of course, the patient voice and trying to improve that clinical pathway for patients with back pain.
And it is interesting because I receive emails all the time from physical therapists asking me, what's the code I should use if I want to provide a cognitive behavioral intervention for my patient with back pain?
Right.
And my question back to them always is, have you screened? Do you have a self-report measure that demonstrates that the patient needs to have that type of care? And
Hmm.
it sounds like what you found in those chart reviews from 9 different clinics, that's mostly absent.
Right. Yeah, exactly. So if you're not screening and assessing it, then how are you justifying treating it?
Well, it's kind of, I'm guessing that the person needs this.
Yeah,
Yeah.
yeah. And we did find that therapists were doing a lot of informal screening.
Yeah.
And so through their conversations, taking the history, goal setting, they were aware of these psychosocial risk factors present in their patients. I mean, we spend a lot of time with our patients, but it wasn't being formally documented.
And do you think that's because we don't have a good screening tool that's appropriate for physical therapist practice or time factor? What are you seeing? Because obviously you're going into clinics and speaking with therapists.
Hmm. Yeah, I think some of the challenges we found were lack of time, lack of maybe, like you said, having the appropriate screening tool. We're not maybe having the belief in the screening tool that it's going to do what it's supposed to do. Is it valid? Is it reliable? Another big challenge that we found when we had focus groups with these clinicians was if they did identify a risk factor, for example, what do they do about it? And
Yeah.
they didn't have the confidence to address it, and they don't have referral sources to refer these patients to help. And so it's almost like let's not get into that or identify it because then we'd have to do something about it.
Right. So that
Yeah.
I think that's a really good segue into bringing mental health into the picture.
Hmm.
Because if we're screening, there are going to be some people that have relatively low or no yellow flags.
Yeah,
Then you're going to have a group in the middle that it's normal with almost every health condition that there are symptoms of things like anxiety and depression.
sure.
And then obviously we have people who are going to screen very high. And as you mentioned, those people need to be co managed or potentially referred out. to a mental health provider, which can be very difficult depending on where you are in the country to find one to collaborate and co-manage with.
Hmm.
Yeah.
Yeah.
So
Yeah.
it's kind of a beautiful overview of really where we are as not only a physical therapy profession, but really kind of where we are as a health system.
Hmm. Right. And I mean, everyone's well intentioned, right? We want to help the patients, help them get better. And for me, throughout my research, it's been a lack of skill and training. So, hence, getting this into entry level education, that's been my mission all along.
So let's segue to that. So how did you start to implement really a vast, the psychological health, mental health, psychology and reform space is really a large amount of information to start to kind of whittle down and say, okay, how do I start to slowly bring this into the
Right.
program? Where did you start?
Well, I started with what I was most comfortable with, which was the pain science piece, because I have a certification, therapeutic pain specialist, and I had studied a lot around pain science for the last 20 years. I would say implementing just the basics of what is pain and, how it presents in the body and the mind, and having that connection, and kind of also debunking some of the myths that people come into the program with around pain. So we started with a pain seminar. Was basically a collaboration amongst multiple faculty members because we were all teaching little pieces of it, but we really hadn't come together as a whole. And we offered that to the first year students for about 6 hours. We had interactive pieces and faculty fun facts and things just to make it, more engaging. We did that for a few years, and then as the faculty got more comfortable with the material and the content, we were all on the same page. We kind of divided that and integrated it throughout the curriculum because 6 hours is quite a bit for students, and it's kind of like a fire hose of information coming at them. So then, taking a more integrated approach is what we're doing now in the first year. And then at the same time, I had developed an elective course for the program. So students are required to take a 3 credit elective or 3 credits worth of electives. And my class was Advanced Management of Pain, which started out being mostly pain science, but some motivational interviewing, quite a bit of pain neuroscience education skills, and then just kind of barely touching into the lifestyle factors. And then this year, I revamped the course after taking your certification in mental health physical therapy. And I really made it more of an emphasis on that idea of patient-centered care, whole person care, and really skill building for them so that they not only had the knowledge and the awareness that these exist, but that they have the skills to go out in the clinic and actually implement some of these interventions
Mm.
around psychosocial health and wellness, health promotion.
Yeah.
Yeah,
I love that trajectory because I believe it's where, a lot of us have we've been on that path.
all right.
And when I listen to you, it's almost like you're telling my story in a way, like came into this, because I wanted to improve pain, so to speak, pain
Hmm.
education,
Hmm.
um, which is an education intervention, but that's not a mental health intervention. That's not a lifestyle intervention.
Right.
And they're really three different things. And I think they get conflated after a while.
Hmm.
Um, so I appreciate how you have been squarely able to kind of separate those three things. And I wonder if you can describe to us how you approach, let's say, the pain education piece, because pain education is obviously important,
Hmm.
and how you started to make that distinct from, let's say, some of the mental health interventions.
Sure. Yeah, and I think the students actually have taught me a lot over the years and helped me evolve the class because it's a very discussion-based, organic course where the students grapple with a lot of these concepts first, and then we talk about it in the larger group. And so some of the key topics that kept coming up were related to this idea of the connection between anxiety and depression and pain, and what do we do about that, right? And not feeling like they had the skills or the tools to even address it or screen for it. Trauma-informed care was another area that, the students, they're very aware of these things. And they've
Yeah.
taught me a lot in the last 5 years about trauma-informed teaching even, right? Because a lot of the concepts that we're talking about with patients apply to student mental health and student well-being as well, which is another area that I'm very involved in. So for me, it's all connected. It's not necessarily separated out. But for the class, the pain really should be called advanced management of a human being,
Hmm.
right? Because pain is a whole person experience, and so really not trying to separate the psychological from the physical, but being able to acknowledge that this approach is going to help the person live better, have a better quality of life, potentially with pain and not necessarily changing the pain. Because I think that's where students tend to get hung up on is that we have to fix something or we have to take this pain away or we have to make it better. And they really struggle with feeling like they have to know all the answers too, and really teaching them that the patient has the answers. They know what's best for them. They
Yeah.
have deeper values and goals that they want to work on, tap into that. So it's been a little bit of a evolution, I would say.
Sounds like you have some really wonderful students that are, helping shape the entire process. And when you're talking about not eliminating pain, I get the sense you're talking about both physical pain as well as emotional pain, which many of our
Mhm.
patients are working through.
Right. Yes, exactly. Yeah. And I'm honored to be able to teach these, emerging physical therapists because they are very passionate. They want to go out and make a change. They want to, do something different, and they really are inspiring to work with.
Yeah, I feel that I feel that as well. I teach a couple of just, you know, short parts of courses that people invite me into, usually on nutrition or psych informed care, and I'm really inspired by a lot of the new physical therapists. At this point, they're students, but they're right on the cusp of going out there, and I can
Hmm.
really feel that they are ready for something different.
Yes.
Different than what we probably graduated with, and a different way to, obviously, as you mentioned, support the whole
Hmm.
person, support the human being. What happens when they now go to the clinic
Right.
and their CI, so to speak, is someone who maybe graduated, I don't know, when I graduated in 1997, and maybe is aware of all these things that are going on and probably has heard about pain science, of course,
Mhm.
but hasn't necessarily changed the way they practice.
Right. I think from what I've seen in the past few years I've been teaching this course is that the students learn how to communicate differently around pain, lifestyle behaviors, coaching, and really the clinical instructors tend to be kind of impressed and surprised that, wow, they're getting more out of this patient in terms of behavior change than maybe I could get in some of these quote unquote difficult patients, right? And really being able to communicate with them in a different way. And I think that's really a big skill that they come out with is how to have these conversations, how to elicit change, how to, get that patient buy-in. So it's been, I think, more positive than not. I feel like when we're talking about these things in class, the students they're concerned about, how is this actually going to work in the real world? But when they get out there, it tends to be a positive experience for them.
Mm. So when you say the difficult patients,
Hmm.
in my mind, that makes me think clinically, probably more the complex
More
patients
complex.
who has both obviously medical and psychosocial factors that are contributing to their pain and recovery, so to speak.
Mhm. Yes, those
And
are the
it's
patients I'm drawn to, right? The
Yeah, those are the
challenge.
patients, those are
Yeah.
the patients that all of us in this space, I think, are now drawn to and attract. But it's interesting to me to think that a clinical instructor with decades of experience is saying, you as the student work with this person.
Hmm. Hmm.
When it should almost be the opposite way around, right?
Right, right.
Right. Which I really think points to the fact that we're doing a good job in our DPT education
Hmm.
with putting things in that prepare new students, new physical therapists to work with the complexity that we now have in the US healthcare system that we probably didn't have maybe 30 years ago. We didn't have as much of it, I would say.
Right. I mean, of course, there's always challenges, right? So, the students have identified that, potentially they don't have that kind of time. That's one of the things that they discuss in their discussions in class that, are we supposed to be experts in everything? How are we going to have time to do all of this? And so really kind of trying to keep that perspective of really it's small changes, little, small steps at a time, very personalized, very individually tailored interventions that make a big difference that you don't have to have all the answers. You don't have to be the expert in everything.
Yeah.
Yeah.
Have some changes in the captive requirements helped you put this into the program, this type of information, this, kind of intersection between pain and mental health, but really more because within the last, I don't know, maybe it's a year or two is really when the mental health component really showed up in the requirements, right?
Right. Yeah, very recently I did write and apply for a grant that I was offered through our teaching center, so the Thompson Center for Teaching and Learning. And it was to help fund my training to bring this into our DPT education program, as well as doing a lot of the curricular revisions and remapping for those new CAPTE standards. So, yeah, I think the CAPTE standards are a little bit more broad now, which is nice. And there is some language around psychosocial aspects of health and health promotion that wasn't there before. It could be improved, honestly, in my opinion, because it's still not quite covering the scope that really our physical therapists can practice within. But it's an improvement, I would say. So yeah, we're in the process of doing a full curricular revision, so it's going to take time to really look at how that can be further integrated.
What's one thing you'd like to see change to the captive requirements that would help, people like yourself, professors, integrate this more readily for students and professionals?
Well, I think the more explicit CAPTE can be, the more likely it is that programs will adopt the content, right? So if it's just kind of a general, broad statement, it can be interpreted multiple ways, depending on the expertise of the faculty, you may get different types of presentations.
Yeah, yeah.
Yeah.
It is interesting because I have a little bit of a because I think broad is wonderful in the sense that it gives you flexibility,
Right.
right?
It's not prescriptive. Right.
Right. It's not prescriptive. In the other sense, obviously, we're preparing clinicians to work with patients, and part of me is like, there still should be a core set of skills that
Yes.
every physical therapist has in every specialty area when they graduate a DPT program, and if that doesn't happen, then we wind up with, professionals coming out with all these kind of, well, I look at it like pieces
Mm-hmm.
of the puzzle at this point versus, bringing things together. And it is challenging because I know colleagues who are working this into the program,
Mm-hmm.
but they're coming at it from almost a deep interest in one thing. Like I'm deeply interested in trauma. And I'm like, that trauma is super important. We're all
Right.
seeing patients, all of us have a history of trauma in some way.
Mm-hmm.
But that's not the only thing that you're going to see in practice, obviously.
Exactly. Yeah, and it's always helpful to go back to what is entry level, right? What is the entry level knowledge, skills, and abilities that students will need to be successful. And for me, in particular, in our program, it's the communication piece. So
Mhm.
noticing that when students interact with clients, even through we have a pro bono clinic where we serve the community, and the students run and lead that clinic. The interviewing skills of someone talks about my, you know, family member just died, and the students, I don't know what to say, right? Like having that ability to have that conversation, those difficult conversations, I think that's a skill that's very much needed. And being able to validate, empathize, reflect what you're hearing, and then, be able to make the patient feel heard. I think that's a really important skill that we tend to gloss over. We call them soft skills, but to me, they're essential skills.
Yeah, they're powerful skills. They're not soft. I don't like that term. Soft skills is
I
an
don't
interesting
even.
one, and I'm like, they're probably some of the more powerful skills you have, especially like the example you just gave,
Hmm.
where we can train PTs about fear avoidance,
Hmm.
and then your patient shows up and says, my husband passed away 3 weeks ago,
Right,
and I'm dealing with grief,
right.
and fear avoidance isn't really going to work so well in that sense, right?
No, no, it doesn't really apply. And I think some of the challenges we saw, and this reminds me of, during COVID, with students still going into the clinic, they were not prepared for the depth and breadth of the psychosocial issues that were happening at that time. A lot of mental health, a lot of distress, illness, right, related behaviors, and how to handle those things, or even being exposed to people are going to die, or suicidality and things like that. They just felt completely unprepared for. And so I think that was another big push for me, is making sure that we had some background and some skill in that area, at least to be aware, if not to be able to, maybe use therapeutic use of self to kind of come alongside those people.
Yeah, really well said. I want to go back to the screening part for a minute because screening is something I've
Sure.
become really interested in the past couple of years. So we have an awareness now that we should be screening.
Hmm.
Every PT should be screening, not just people who are working, not just if you're working people with pain or
Right.
potentially comorbid mental health conditions. Everyone should receive a screen. In your work, do people follow up on the screening? And not only like, because in my mind, I'm like, well, there's following up at, let's say, the 4 or 8 week period.
Hmm.
And then there's following up at the discharge period. And maybe even beyond discharge, let's say, 30 to 90 days, because I've heard things from some of our colleagues who are not as skilled in this area as you are. And they say things like, well, as physical therapists, there's nothing we do that improves mental health. Yeah, and it makes you kind of like flinch, right? For those of you
Yeah.
that are listening to this and you can't, see our video here. I firmly believe that even if you've never taken any kind of psychologically informed training,
Hmm.
that one, we have a very good therapeutic alliance.
Hmm.
Two, obviously, decreasing someone's pain, improving someone's physical function has an impact on their mental health. We're just not necessarily tracking it.
Right. Right. Yeah, and this idea of outcome measure outcomes, not the, effects of the therapeutic intervention. So, yeah, I think that's really falling short of the mark, honestly, that movement is helpful for mental health, just looking at it as simply as that. But I don't think you can take away that piece of it from working with a person, right? We all have behaviors, and to me, we're in the business of behavior change. So you can't have behavior without psychology. And really, I think potentially that might be just, again, that lack of confidence and not knowing how to address these things. But to answer your question, short answer, no, they were not following up. If they were screened, then they weren't screening again at, reevaluation, discharge. So that was something that we did look at in our chart audits. Again, a small sample, but it's probably pretty representative of common clinical practice, at least in this area of Michigan.
I wonder how physical therapists would feel if they actually tracked pre-intervention and then post-intervention, let's say, and saw that depression and anxiety decreased
Hmm. Hmm.
without necessarily even targeting depression, anxiety. Because thinking back to what you were saying, the students are saying things like, well, you've introduced me to these wonderful concepts and some basic skills,
Hmm.
but do I have to do everything? And when people say that to me, I think they're saying, do I have to actually treat the pain, so to speak, and at the same time treat the depression, almost as if they're like two different treatment approaches?
Right, right. When they really should just treat the person.
Right. And just treating the person, in treating that whole person,
Yes.
you directly or quote indirectly target though, wind up influencing both of those factors. And I think if we had a whole profession that was looking at pre and post outcomes, let's just say 8 weeks, you'd find that, wow, because I've done some of this work, some of this study, that, wow, what
Mhm.
we do actually does have an impact on every one of my patients' mental health has been impacted in some way.
Sure. Yeah, and I think it goes back to that problem of always separating mind from body, right? We really need to get away from that idea that it's one or the other. It's both and it's always both and. And I know you've done a lot of work around depression care, and, physical therapy is extremely helpful
Yeah.
in that area. So, yeah, I think probably, again, one of my missions is to try to debunk some of these myths around pain so that students feel that they at least, can approach things and not feel so overwhelmed that I have to treat everything.
Right. Right.
Yeah.
What would you like to see from the educator perspective? Because not every program, to my knowledge, has elective courses and things like pain.
Hmm. Hmm.
Would you one day like to see, let's say, a separate pain course and a separate mental health course, or do you think we should keep these things grouped together? What would be your vision if you were revamping the entire curriculum, so to
Yeah.
speak?
If I was a decider of one for the whole curriculum,
Yeah,
I would love to see it integrated. I think that's really the best way to learn is to have exposure, basic knowledge and skills, and then build on that, scaffold that knowledge up through and those skills through the curriculum. And I would love to see my class be a permanent class in the curriculum, not an elective, that
mhm.
it's required. Because again, every PT needs these skills, every new grad needs these skills. So I think integrating the content, making it not just a one and done kind of class would be ideal. So that's really what I'm working toward, hopefully, and looking at the health promotion competencies that were put out in 2020, making sure that we're hitting on those throughout the curriculum, and then, making sure that we can map that all back and, of course, have the CAPTE standards as well. So,
And did
yeah, that.
those health and wellness competencies that were published? I think it was Dawn Magnuson that published those. Great work there. Did those talk much about mental health, so to speak?
A little bit, actually. Yeah, there's some in there. There's, nutrition, more the lifestyle behaviors, but I do think that it is a nice way to ground the mental health piece in the curriculum.
Yeah,
And again, my perspective is always integration versus separate. Because, students will associate one class with one professor and then never think about it again if
yeah,
they go into further classes and you have to remind them, right? Remember
yeah.
this was something that we talked about. And so I think the more we can integrate, the better the students will be able to come out of the program with those skills and implement them.
And I would imagine there's space for integrating it or seeding it throughout the curriculum, as
Mhm.
well as having a separate course
Right.
that
Yeah.
goes deeper into the topics if you're interested.
Exactly. That's what the electives are really for, is to go in a deeper dive, beyond that maybe basic entry level.
Yeah.
Yeah.
Sarah, it's been great speaking with you. If clinicians, educators, researchers, anyone would like to contact you and learn more about how you're doing this or the successes that you've had or the challenges that you've had within the curriculum, how can they reach out to you?
Well, I'm not on a lot of social media, so I would say my University of Michigan email is probably the best. If that can be shared, that's the best way to get in touch with me.
Good. We'll include a link to Sarah's email if that's okay with her, so that you can find her. And of course, if you can't find that, you can reach out to me here at the Institute, and I'm happy to connect you with Professor Case Morris so you can learn more about how she's integrating pain management, health and wellness promotion, and mental health into the DPT curriculum. I'm Dr. Joe Tatta. Thank you for being here with me this week. Stay tuned for another episode next week, and I'll see you soon. Thank you for listening to the Pain Science Education Podcast. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates and learn about our continuing education courses. If you enjoyed this episode, leave us a review on your favorite podcast platform and share this episode with your friends. Please join us next week as we share more science-backed solutions for treating and reversing chronic and persistent pain.